Hi everyone and welcome to the Clinical Conundrums videos. My name is Hesham Ibrahim. I'm one of the emergency medicine consultants in United Kingdom, and today we are going to cover the final part of that long case that we've been discussing over the past few videos, and today's video is going to be the last one in this series. Before we make a start, I'd like to quickly announce for the next emergency physicians ECG course. So the next virtual one will be done via Zoom, and it will be on the 21st of September 2023. So I'll leave a link to the booking page in the show notes if anyone is interested. And the second and final announcement is about the From Zero to Hero in ACS ECG course. This is a recorded course that covers everything you need to know about ACS ECGs. Again, it is available online. I will leave a link in the show notes. And without any further ado, let's move on to our case. So a quick recap of what we've covered so far regarding this case. So we discussed a 23-year-old male patient that I've seen a few years ago, presented to ED with chest pain that sounded pleuritic, with shortness of breath of sudden onset. So when I examined that chap, he's had a midline sternotomy scar that was noticed in the front of his chest. I clinically suspected pulmonary embolism in this case, so I started treating this with anticoagulation when I had the surprise that the patient is known to have heparin-induced thrombocytopenia. So he received danaporoid sodium instead of heparin, and he was referred to the medical team for admission so he can have a CT pulmonary angio and further treatment under the care of the medical team. So a chest x-ray was done just before moving the patient to the medical ward, and I had a look at the chest x-ray, and this is what I found. So this was the chest x-ray, and it had this big surprise weird thing there, and the question was, what is this? And today we're going to try to cover the answer to that question. And the answer to that question is, this is an LVAD, a left ventricular assist device. So let's talk about this interesting device. So LVADs have other names. They sometimes call them the durable mechanical circulatory support device, but LVAD stands for left ventricular assist device. It is a device that helps pumping blood from the left ventricle to the rest of the body in case of severe heart failure. So basically, you can imagine as if you've got a non-functioning or very poor functioning left ventricle and you're trying to bypass this. So what will happen is that you will be taking the blood from the left ventricle via this cannula here, and then you're gonna just shunt the blood all the way to the aorta using a pump force to push it this way. So this is basically what LVAD means. So there are several indications to insert an LVAD to a patient. You can put a temporary one as an interim measure. So that happens sometimes for patients who are awaiting heart transplant, but there is no available candidate yet. So they have the LVAD as a temporary measure. It happens also for those who have severe heart failure that is secondary to a temporary cause. So they use the LVAD sometimes as a bridging to treatment device. So that's regarding the temporary use of it, but it can also be used as a permanent device or as a permanent destination therapy, and that is for cases where heart transplant is not an option. So in terms of how it works, the important thing to understand about LVAD is that this is a pump that changes the pulsatile flow that we normally have in our hearts into a continuous linear flow. That is the most important thing that you need to understand. So this basically will replace the pulse to a continuous steady flow. So this is the patient who will be alive talking to you with no pulse. So let's talk a bit more about this, and let's focus on the presentations of left ventricular assist device in ED. So because the LVAD changes the arterial flow from pulsatile into a linear, there will be some consequences to that. The first is there will be no pulse to feel. So again, this is a patient who will be sitting talking to you, and you will feel the radial pulse and you will find nothing. This is a patient who will have no systolic or diastolic blood pressure. You can only measure the mean blood pressure, but you cannot really have a systolic or diastolic because there is no pulse, there is no pulsatile flow. And lastly, if you try to listen to the heart sounds, you will hear nothing other than what we call the LVAD hum. It's basically just a continuous noise coming from that machine. Sometimes they say it's very similar to a dishwasher noise, and when you listen to it for the first time, this is exactly what you're gonna feel that you're hearing. It is just like a continuous noise of a dishwasher. So the mean pressure can be measured using two ways. Either you do it via the manual blood pressure cuff or via an arterial line. The arterial line is preferred because it's going to give you a continuous measurement, but if you don't have this facility or to buy time while you're preparing for your arterial line set, you can use the manual blood pressure cuff to do it. And here is how to do it. Basically, you'll need to have a Doppler machine in hand. You inflate the blood pressure cuff, and then you place the probe over the of the Doppler over the radial artery, and then you slowly go down with the blood pressure cuff till you start listening, hearing your first sound coming from your Doppler probe. And when you hear this, then the number on your blood pressure cuff at this point of time is the mean blood pressure. So you're going to hear only one single sound rather than two Korsakoff sounds like what we normally hear. Now the question is, if you have a patient with no pulse, no systolic or diastolic blood pressure, and no heart sounds, how would you know if this patient is having a good perfusion or not? That's the question. Well, there are different ways to assess the perfusion. You can do this via assessing the mental state of the patient. If the patient is sitting up, talking to you, fully conscious, fully aware, that means that the brain is well perfused. You can assess the capillary refill time, and you can feel the hands and feet to see whether they are warm and well perfused or really cold and poorly perfused. And if you have the time, you can measure the urine output hourly and check whether the kidney is well perfused or not. And now we come to the interesting part of this talk, which is the cardiac arrest in a patient who's got an LVAD in place. So there are a few questions to ask about this. First question is, so this is a patient who's normally with no pulse, no blood pressure, and no heart sounds. How on earth am I gonna confirm the cardiac arrest or assess for ROSC for a patient like this? That's the first question. The second question is, so is it okay to do a CPR for a patient who's got an LVAD in place? This is a device that is attached to the heart, connecting the left ventricle to the aorta. How about the mechanical compression there? Can this cause any dislodgement or cause any harm? So that's the second question. And the third question is, how about DC shock for patients like this? This is a patient who's got an electronic device attached to the heart. Is it okay to give the DC shock to this patient? Can this cause any harm? Can this affect the machine? So these are the questions that we're going to try to answer now. So let's start with the first question, how to confirm cardiac arrest or ROSC? Well, you can use an echo, and that will give you an idea whether you've got a contracting left and right ventricles or not. So that will be your starting point. You can also determine whether the LVAD is working or not via auscultating the chest for a hum. You can use an art line to assess the mean arterial pressure. And lastly, you can check the other signs of perfusion, like the perfusion to the brain via assessing if the patient is conscious or not, via checking the end-tidal CO2 to check the perfusion to the lung, etc. So these are different tools that you can use to confirm cardiac arrest or to confirm the ROSC. How about CPR with LVAD? Well, interestingly, the manufacturers recommend that you do not do CPR, and that is because they are concerned about the device being dislodged, which is quite an interesting thing because, come on, this person is in a cardiac arrest. This person is almost dead. So what else are you going to wait for before doing something? Personally, I would start CPR immediately for a patient like this. The only caveat to this is that you need to make sure first that this patient has no cardiac output rather than no pulse, because normally those patients, they don't have pulse. There are some talks about using abdominal compression versus chest compression for these patients, but I couldn't find enough evidence to support this, so I'm not going to cover this in this talk. We're sticking to just the normal chest compression at the moment. And finally, DC shock with LVAD. Can we do it, or there are concerns here as well? Well, actually, you can just do it. If you think that your patient needs a shock, then you shock them. So that applies both to cardiac arrest rhythms and to dangerous arrhythmias. So basically, just treat this patient like any other patient who's got a pacemaker in place. And same as with pacemakers, try your best to avoid placing the pads on the LVAD if you can do this. So that's the only caveat to this. That's the only thing that you'll need to be aware of. Other than this, you just treat this patient as if it is just like any other patient that you've had before. So this is the end of this long, tough case that I've had. So thank you so much for your attention and for watching the video. And I'll be looking forward to talking to you very soon about a different case. Thanks a lot and have a good day.